It's a pleasure to introduce our distinguished speaker, Dr. Sughra Raza. Dr. Raza is a professor of radiology in breast imaging division. Also, she's the division chief for the global radiology at the University of Massachusetts Medical School. She's a fellow of the American College of Radiology and Society of Breast Imaging. She's born and raised in Pakistan, had her undergraduate and medical college in Buffalo, New York, and Albany, New York. In terms of her professional career, she had 30 years as full-time clinical faculty at Harvard Medical School, from instructor to associate professor. Recently, she began working independently as a consultant breast imaging radiology at BIDMC Hospital and at Harvard Medical School. She has special interest in early detection of breast cancer and diagnosis, especially in limited resource regions of the world. She hopes to expand on this work now that the pandemic is somewhat in control. Most of this effort has been in Rwanda. Recently, she was appointed the editor-in-chief for the Journal of Global Radiology. This journal aims to provide an accessible platform for researchers around the world, focusing especially on radiologists in low resource settings. Today, Dr. Raza is going to talk to us about guidance for getting your work published. Thank you so much, Sughra, and welcome.
Assalamu alaikum. I am Sughra Raza. I'm a breast imager in Boston, Massachusetts, and I am grateful to Dr. Shaheen for inviting me to speak at this milestone conference in Gaza addressing breast cancer care. This talk is titled Better Care Through Clinical Research, Mentorship, and Publication. And there aren't many pictures, but I'll try to talk through it efficiently. I'm going to review some global breast cancer data. I will emphasize the need for clinical research, and I will, at the end, introduce the Journal of Global Radiology and put forth some mentorship ideas for you. So globally, the current data says that there are 7.8 million women with a diagnosis of breast cancer if you look at the 5 years ending in 2020. Also in 2020, there were about 2.3 million women with a new diagnosis of breast cancer and 685,000 deaths from breast cancer around the world in 1 year. Women lose more disability-adjusted life years to breast cancer than to any other cancer. And unfortunately, the incidence of breast cancer, while it is highest in the high-income countries, mortality ratio is higher in the low and middle income countries. So we have a lower incidence in the resource limited regions of the world, but a higher mortality. And this is because of usually later detection and fewer treatment options being available. It's estimated that by 2035, 2/3 of new breast cancer diagnoses will be occurring in developing countries. Some of the mortality to incidence ratios in Africa, in the Middle Eastern and West African regions, are as high as 0.55 compared with 0.16 in North America, where cancer is usually often detected through screening. It's often very small, node negative, easy to treat, and mortality is almost rare. The 5-year survival in high-income countries from breast cancer is better than 90%, while in India, it's 66%, and in South Africa, it's only 40%. We know that early detection and treatment has been extremely successful in the high-income countries, and this really needs to be used in the rest of the world, especially in regions where some of the standard tools are available. So we need to somehow be able to provide access to the care. High-income country age standardized breast cancer mortality decreased by about 40% from the 1980s up to 2020. Annual breast cancer mortality decreased by 2 to 4% per year. So the thought is that if we can achieve worldwide reduction in the annual death rate from breast cancer by about 2.5% per year, we may be able to avoid or avert 2.5 million breast cancer deaths by 2040. This is based on research and assessment done by the World Health Organization In March of 2021, the WHO announced their Global Breast Cancer Initiative. The goal of this initiative is to reduce global breast cancer mortality by about 2.5% per year, thereby avoiding the 2.5 million cancer deaths by about 2040. Such a reduction would avoid a quarter of breast cancer deaths by 2030 and 40%, almost half, by 2040 among women under 70 years of age. The WHO response, the GBCI, Global Breast Cancer Initiative, aims to do this using 3 pillars: health promotion for early detection, timely diagnosis, and comprehensive breast cancer management. Let's just review quickly treatment and outcomes of breast cancer. We know that optimal treatment depends on stage of disease, tumor biomarkers, including hormone receptors and HER2, or human epidermal growth factor receptor 2. Prognostic factors include tumor size and grade, as well as the biomarkers and local and regional nodal involvement. These prognostic factors are based on histopathology review, and they lead to treatment decisions, right? All of those ideas and concepts are based on evidence-based design and medicine, practice of evidence-based medicine. The idea that optimal treatment depends on the stage that the patient presents at, the biomarkers, the type of cancer, nodal involvement, all of that, this evidence has been amassed and accumulated over many decades in Western developed countries. It primarily comes from high-income country data, therefore represents the populations in those countries, right? We don't have this kind of evidence-based data yet from low and middle income countries that is reliable, reproducible, and done to high standards. We need to figure out the incidence of breast cancer, the types of breast cancer that occur in different parts of the world, what the most affected age groups are, what genetic mutations are common. And so we know what's common in women of Northern European descent, which is primarily all of the HICs, right? The high-income countries and the Western world. But we don't know what we have in a majority of the rest of the world. What are the other risk factors in Asia, Africa, elsewhere? So this need for data is critical. We need to know population. It can only be collected through organizations that participate in population-based cancer registries, which in most LMICs are quite limited. Even if they exist, they're not reliable. Everybody doesn't comply. They often don't even include some details like anatomic staging of breast cancers at the time of presentation. They may not include biomarkers because everybody doesn't get tested for the biomarkers because of lack of ability or resources. Detailed prognostic features are not known. All of this limits effective treatment decision-making and prognostics. Data collection can be done at multiple levels: at the national level through nationally organized tumor registries, through screening programs; at a local or hospital level, again, through tumor registries, and also through outcomes analysis. And this can be in different departments. You know, breast cancer is a very multidisciplinary problem. We work most closely with our surgery colleagues, with our oncology colleagues, and with our pathologists. And outcomes of each of these different subspecialties that work with breast cancer can provide very important data. In breast imaging, since that's what we're here talking about, or I am at least, we have audits of our screening programs. We look at the outcomes of our diagnostic mammography services. We carefully look at all our core biopsy outcomes to do radiologic pathologic correlation and collect all of this data. So let's talk about what clinical research means. It's a systematic investigation which can include research development, testing, and evaluation. It's designed to develop or contribute to generalizable knowledge. That's a very broad definition, and it can include biomedical research, epidemiological studies, health services and reutilization research. It can also include study of behavioral and social and economic factors that end up affecting health and healthcare. And as I said before, data collected in different subspecialties that are involved in breast cancer care can be used to look for patterns and recurring themes in the clinical setting. This is a common approach which has been used in epidemiology, health services research, and public health aspects of research. And it includes the analysis of the patterns we see of different things occurring, determinants of occurrence, natural history of the disease, evaluation of healthcare interventions and services, as well as utilization. Drug safety surveillance is part of this kind of assessment, of course, and some genetic and social studies. So this, again, to reiterate, tracked data can provide outcomes of treatment or public health interventions that are offered and put in place, functional abilities of the system, patterns of care in different regions of a given country or a given continent, healthcare costs and utilization. And then we need feedback from real-world clinical on-the-ground experience so that we can compare and improve the use of different interventions, whether they be imaging, diagnosis, drug treatment, vaccinations, medical devices. This is obviously a generalized idea of data collection. In low and middle income countries, there's such a disparity of disease burden to available resources that it can feel daunting, but this is what we want to address, right? We need contextual and firsthand experience of the common challenges that people in low and middle income regions face. There are many obstacles to clinical research in certain parts of the world, poverty being a big one, health systems being somewhat fragile and lacking. Political instability. There are frequent policy changes from the government that may impact research. There's a lack of research infrastructure. Maybe we don't have enough staff to manage the data. There can be cultural or religious obstacles, although I think these are talked about more than they are real. But lucky for us, despite all these challenges, there is more clinical research being performed in low and middle income countries, which is great, and which brings me to introduce the Journal of Global Radiology. This was initiated by my very highly respected, wonderful colleague, Dr. Sarwat Hussain, who grew up in Pakistan like I did, and he has been based in the Boston area for many years. He took it upon himself to start this journal in 2014. It is a peer-reviewed, open access, specialized journal that documents and studies issues particularly surrounding global access to and delivery of medical imaging services. This is not focused on breast imaging. This is a general radiology journal, but the focus is to provide a platform for research being done in low and middle income regions of the world, which may not get widely disseminated otherwise. The Journal of Global Radiology explores practical and technological challenges in such regions, and especially, obviously, as they pertain to radiology and medical imaging. And we also want to look at medical education, economic and infrastructural development, and public health and health policy issues in those regions. So basically anything to do with radiology and providing medical imaging for proper health care in these areas. Launched in 2014, we had only 3 manuscript submissions the first year, and I have given you data for each year since then, and you can see that we've had a dramatic increase in the number of manuscripts submitted and therefore published. In 2022, in the first 6 months, we already had 34 manuscripts submitted. We're projecting that that will likely double by the end of the year. This has been fantastic. The current issue includes an article from Rwanda, one from Pakistan, one from India. The scope includes advocacy, education, communication, collaboration, and expansion. And I'm not going to read out what all of these stand for. I have taken this directly from the website of the journal. So if you just Google Journal of Global Radiology and go to the journal's homepage, you will find all these things. But this is what we really want to focus on, that we want to provide a platform for limited resource regions of the world where research is being done, where there are committed scholarly radiologists who are conducting very sound research. We want to provide a platform for them to publish it and disseminate it so that it can be used wherever it can be applicable. The article types in the journal are typical of any medical journal. We publish original research, pictorial essays, reviews, and invited commentaries, editorials, again invited. There's a section on global vision, which focuses on future developments in radiology pertaining to delivery, education, research, even including businesses that would have, or industry that has connections to medical imaging, as well as equipment. Imaging challenge or interesting cases, letters to the editor, books and software reviews. We have a special state of radiology article type, which focuses on the radiologic assessment or medical imaging assessment in a given region or developing country. Technical notes, as you can imagine. The thing I want to talk most about is the fact that many times, even when sound research is being done in limited resource regions, that research doesn't get published, or if it does, it's in the local or regional literature with little wide dissemination. This may be due to lack of training or experience in study design. Sometimes there isn't good mentorship. Sometimes there's difficulty with the English language, so it doesn't get disseminated widely. There may be a statistician lack or support. JGR offers collaboration between these scholar radiologists in limited resource regions with scholars and radiologists in the developed countries, and so that we can help write up their studies. We are referring to this as the Scholar Twinning Program, and I'll just explain a little bit about that. So when a manuscript is submitted to the JGR and the initial review by the editor-in-chief shows that the idea is promising, that the data is sound, that this should really be published, but the manuscript needs significant help, we will offer the authors the idea of scholar twinning. If they agree, the JGR editor will select an appropriate mentor, which may come from our team of reviewers or editorial board members, or we might find other experts in that subspecialty. Remember, I said this is not just breast imaging, this is all of radiology. So and just so you know, I'm not trying to hide this. I am the editor-in-chief of the JGR currently, and I do know a lot of people around the country. The manuscript is then reviewed, and we work with the authors to revise it up until a point that it's ready to be sent for blind double review, and then it gets published. And the mentors in the Western world who have helped polish up the manuscript also become authors. So please remember the Scholar Twinning Program, which leads to a win-win situation for everybody involved. And I hope you will submit your articles. This is an example of the most recent one I worked on with some wonderful radiologists in Cairo. And we published this in the Journal of Radiology, of Global Radiology last year. It was a very interesting case report. I thank you for your attention and enjoy the rest of the meeting.